Welcome back, everyone, to our Research Connect series. My name is Jordan Bird, and I'm a CDTRP trainee. I will be facilitating today's webinar. First, I would like to acknowledge that the CDTRP is hosted by the University of Alberta, which is located on Treaty 7 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, and Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. I encourage you to write your land acknowledgements in the chat box. I would also like to acknowledge Estelis, whose generous support we could not have been able to host these sessions without. Before we dive into the main content, I would like to pass it over to Erica for some general CDTRP updates.
Thank you, Jordan. Today I have one announcement. Our innovation grant competition is open. CDTRP is offering $30,000 in seed funding for innovative pilot projects related to donation and transplantation. If you're interested, you have until April 1st to submit your application. A link will be put in the chat shortly. That's all. Back to you.
Perfect. Before I introduce the speakers, I just have a couple of housekeeping notes. Today's session is recorded and posted on the CDTRP website and YouTube channel. During the presentation, please keep your mics off. If you have any questions or comments, you can raise your hand with the raise hand button or type it in the comment section. I'm very pleased to introduce today's speaker, Ms. Eva Amzallag, in the annual scientific meeting We Are Not Yet Done series. Ms. Amzallag holds 2 master's degrees from the Université de Montréal, anthropology in 2018 and epidemiology in 2024. She is currently pursuing a PhD in epidemiology and is expected to complete her graduation by 2027. Her research, under the supervision of Dr. François Martin Carrier, examines the relationship between blood transfusions and postoperative pulmonary complications in liver transplant recipients. I will now hand it over to you.
Thank you, Jordan. So, hello, everyone. I'm Eva Amzallag, a PhD candidate in epidemiology at Université de Montréal, and I'm thrilled to be here today as part of the CDTRP Research Connect series. So thank you very much for having me, and thank you all for being here. So today we're going to talk about something that if you work in transplant medicine, you probably encounter every day: blood transfusion. They're essential, they save lives, but do they also come at a cost? And more specifically, do they increase post-op pulmonary complications and impact long-term survival in liver transplant recipients? So just a quick note, have no conflicts of interest to disclose for the study. Everything I'm presenting today is purely based on our research findings. So let's dive in. Here's how we're going to spend the next 35 minutes. First, we'll talk about why do PPCs matter, post-op pulmonary complications, why do they matter, and how do transfusions affect lung function. Then we'll tell you how we designed our study to answer this question, and also what did we find, and more importantly, what does it mean? And lastly, how can we apply this knowledge to improve patient outcomes? So before I start, as with any good research project, this was a team effort. I was fortunate enough to work with an amazing group of epidemiologists, clinicians, and biostatisticians at the CHUM. Special thanks to my mentor and CDTRP investigator, Dr. François Martin Carrier, who is here today also. Without him, this project wouldn't exist, and without our team, I'd probably still be stuck cleaning data. So let's start with the background. Why are PPCs such a big deal in liver transplantations? Well, studies show that 35 to 50% of liver transplant recipients may develop PPCs, and their impact is serious. That means longer ICU stays, more ventilator dependence, and higher mortality. So let's put that into perspective for a second. If we have 10 transplant patients, 3 to 5 of them will develop a major pulmonary complication, and some won't survive. That's why preventing PPCs starts with understanding what's driving them, which brings us to blood transfusions. So on this slide, studies on the subject show us that blood transfusions are not a neutral intervention. They can impact lung function in different ways. TRALI, which is transfusion-related acute lung injury, happens when donor antibodies trigger an immune response, damaging the lung barrier and causing non-cardiogenic pulmonary edema or acute respiratory distress syndrome. It's also known as that. We also have transfusion-associated circulatory overload, which is TACO. This contributes to cardiogenic pulmonary edema due to volume overload. So that leads to respiratory distress and a bunch of other problems. And lastly, we also have the TRIM effect. On top of the immunosuppression from the transplant itself, transfusions add another layer through the TRIM effect. So TRIM can lead to a broader immune modulation. It could further suppress the immune system, increasing the risk of infections like pneumonia and inflammation, which may cause worse pulmonary outcomes. So one way to explain the TRALI and TACO is the two-hit theory. The first hit is the patient's underlying condition, which may be the liver disease, surgery, and inflammation, already putting stress on the lungs. And the second hit comes from the transfusion itself. So whether through TRALI, TACO, or TRIM, it can happen. These mechanisms are very well documented in literature, but a lot less in liver transplant recipients. So here I put the classic definitions of TRALI and TACO. They're the two best known transfusion-related lung injuries, but those definitions are really strict. So TRALI requires a non-cardiogenic cause, meaning we have to rule out volume overload, and TACO requires evidence of fluid overload, often with hypertension or heart dysfunction. So, but here's the issue. Those definitions are important, but clinicians often see pulmonary edema that doesn't fully fit into either category. Some cases have features of both, while others don't meet all the strict criteria, but still contribute to morbidity and mortality. So yes, these mechanisms can explain some cases, but they don't account for the full picture. The thing is that PPCs are far more common than TRALI or TACO. While TRALI affects up to 1.3% and TACO about 8.8%, depending the cohorts, PPCs may happen in 35 to 50% of liver transplant recipients, as we saw before. So just because these complications don't fit within classic definitions doesn't mean they aren't influenced by transfusion. So you might ask, but TRALI and TACO are also multifactorial. Why look at PPCs outside their definitions? That's absolutely true, but both TRALI and TACO involve multiple factors, including immune activation, fluid shifts, and pre-existing conditions. However, their definitions remain relatively strict. Like we saw, TRALI requires clear evidence of non-cardiogenic pulmonary edema, and TACO requires documented volume overload. So in practice, clinicians see many cases of post-transfusion pulmonary edema that don't fully meet this criteria, but again, they still contribute to significant morbidity. So in liver transplant recipients, the interaction between transfusion, surgery, and underlying organ dysfunction creates a unique risk profile. Pulmonary complications may not always present as classic TRALI or TACO, but still have clinical consequences. So by looking beyond those definitions, we acknowledge that transfusions may impact pulmonary functions in a way that extends beyond traditional categorization. So we don't reject the definitions, but we build on them by acknowledging that PPCs extend beyond strict definitions. So this broader framework is key to understanding why PPCs happen so often in liver transplantation, and that's exactly what our study aimed to investigate. So giving this broader approach to PPCs, we asked the question, do blood transfusions increase PPCs and affect long-term survival in liver transplant recipients? This question is important because while we know transfusion can contribute to lung injury, their overall impact in liver transplant recipients remains unclear. If transfusions worsen PPCs and PPCs are linked to worse outcomes, this could have major implications for transfusion strategies and patient management. So to tackle our research question, we structured the study around three key objectives. Our first objective focused on intra-op transfusions, those given during the surgery. We wanted to see if they were linked to PPCs in the first week post-transplant, as well as graft and recipient survival at 1 year post-transplant. But we know that transfusions don't stop in the OR. So our second objective took a broader look at peri-op transfusions, extending from the surgery through the first 7 days post-transplant. This allowed us to see if the risk changed over time. And finally, for our third objective, we wanted to know what happens after a PPC develops. Does having a PPC affect long-term graft and patient survival? By doing this, we wanted to capture both the immediate risk of transfusions and their longer-term effects on transplant survival. So based on everything we've discussed so far, the high incidence of PPCs, the known effects of transfusions on lung function, and the broader peri-op factors at play, this leads us to our hypothesis. So we hypothesized that peri-op transfusions significantly increase PPC risk and harm both recipient and graft survival in liver transplant recipients. In other words, we expected that transfusions would mean more PPCs and ultimately worse long-term outcomes. So to answer our question, we conducted a cohort study at our hospital, the Centre Hospitalier de l'Université de Montréal, the CHUM. It's a center that performs around 60 liver transplants per year. So our study was, of course, ethically approved by the CHUM's Research Ethics Board, and we were granted a waiver of written informed consent for our study. So we included all adult men and women aged 18 and older who underwent a liver transplant for end-stage liver disease between 2008 and 2021. We excluded patients with non-ESLD indications as their underlying conditions may have different pulmonary risk profiles. Retransplantations were also excluded, and we removed the one case involving liver-lung transplant since these patients have different pulmonary risk. Finally, we also excluded intraoperative deaths since they couldn't contribute to our analysis of post-op pulmonary complications. So with these criteria, our final study population included 640 liver transplant recipients. So what did we measure? We focused on two key things: transfusions and post-op pulmonary complications. First, transfusions for the first and second objectives. We looked at intra-op transfusions, meaning those given during the surgery from the start of the transplant until the patient left the OR. Then for the second objective, we expanded that to peri-op transfusions, which include not only the intra-op period, but also up to 7 days post-transplant. Second, PPCs for the third objective. We define PPCs as the first occurrence of either pulmonary edema or pneumonia within that first week. So we categorized our exposure of a blood product in different ways. So we did that. We did it in 3 different ways to capture both the present and extent of exposure while addressing potential biases. First, we did a binary classification. It's a simple yes/no question that the patient receive a transfusion. This helped us to compare transfused versus non-transfused patients and also assess the overall association between transfusions and outcome. Second, we categorize them by blood product type because not all transfusions are the same. We categorize them into red blood cells and hemostatic blood products, which include platelets, fresh frozen plasma, and cryoprecipitates. So this breakdown helped us to see whether specific blood components have different effects on PPCs and patient outcomes. And lastly, we didn't just look at whether the patient was transfused or not. We also considered how much they were transfused. So to do this, we examined the total number of units received. But as you know, some patients get a massive number of transfusions, which can sometimes skew the results. So to limit the impact of extreme outliers, we winterized at 10 units, meaning any values above that were capped, but we're still capturing a meaningful range of exposure with 10. So we also ran a sensitivity analysis. We looked at total units of RBCs and hemostatic blood products again, but without winterizing. So now let's go over our study outcomes. Our primary outcome was the incidence of post-op pulmonary complication within the first days after liver transplant. We included non-cardiogenic pulmonary edema, ARDS, cardiogenic pulmonary edema, and pulmonary edema of undefined etiology, which I will define in the next slide, and pneumonia. So why did we observe a 7-day period? It's because according to studies, the peak need for transfusions happen immediately after surgery. ARDS also typically develops within 24 hours of a trigger. And cardiogenic pulmonary edema usually happens within 72 hours. For pneumonia, the rates increase by post-op day 6. So we thought that the 7 days was an ideal time frame to capture early PPCs. In addition to PPCs, we also looked at long-term outcomes, as mentioned, such as graft and recipient survival at 1 year post-LT, liver transplant. So what exactly are PPCs? We've been talking about them for the last 16 slides. Well, research includes several complications under the same umbrella. So atelectasis, pleural effusion, pulmonary edema, and pneumonia. But not all PPCs carry the same weight. So pulmonary edema and pneumonia stand out because they have the strongest associations to poor outcome in liver transplant recipients. They don't just prolong recovery, they can seriously impact survival. And also, as you can see here, not all pulmonary edema is the same. We categorize it into 3 types. The 2 first ones are well-defined in literature, and the last one's definition comes from us. So ARDS comes from the Berlin definition. It's a severe non-cardiogenic lung injury caused by inflammation and fluid accumulation. There's also CPE, cardiogenic pulmonary edema, which is a fluid overload, often linked to heart failure. And also for our study, there's pulmonary edema without a defined etiology. Those are cases where pulmonary edema is mentioned in the imagery report, but no clear diagnosis is in the medical notes. So we may ask ourselves why the distinction matters, because treatment depends on the type. So cardiogenic edema, we use diuretic most of the time or other medication, and ARDS, while lung protective ventilation is key. And then, of course, there's pneumonia, and I don't need to tell you, pneumonia in liver transplant patient is bad news. The CDC, this definition that we use comes from the CDC. It requires a combination of imaging findings and clinical symptoms on top of worsening respiratory function. So on to the fun part, how we analyze the data. First, we have the descriptive statistics. We looked at patient characteristics, all stratified by intraoperative transfusions. For our first objective, we use fine and grade sub-distribution hazard models to estimate the risk and account also for competing events like retransplantations or death. Next, for the second objective, since the exposure is time dependent, we use time-varying Cox models and analyze PPCs both as a composite outcome and by specific types, pulmonary edema and pneumonia. We also generated cumulative incidence curves using adjusted Cox models. Finally, for our third objective, we looked at long-term survival, as mentioned before, using the same Cox proportional hazard models. Of course, we adjusted for key confounders, age, sex, MELD score, blood loss, baseline central venous pressure, preoperative status. We also checked, of course, for multicollinearity, and no major issues were detected. So our main finding was rather striking. Perioperative transfusion increased the risk of PPCs by 77%. And this, of course, is a hazard ratio after adjusting for key confounders. This means that at any time during those 7 days, patients who received transfusions were 77% more likely to develop a PPC compared to those who did not. For our key results or other key results, our descriptive statistics, we noted that 39% of patients received intra-op transfusions, while 66% had at least one peri-op transfusion. Interestingly, 100 patients were transfused only in the post-op period, which shows that the needs for transfusion goes beyond the intra-op period. If we look at the PPCs and transfusion influence, so we saw that peri-op transfusion were associated with the 7% increase in PPC risk. And pulmonary edema, very interestingly, the risk of pulmonary edema doubled in transfused patient with an adjusted hazard ratio of 2.30. And not shown here, I didn't mention it here on the slide, but cumulative RBC transfusion were associated with pulmonary edema in a significant way also. So, however, we did not find a significant association for pneumonia or intra-op transfusions alone, suggesting that timing and transfusion burden might play a key roles. And also, one thing that we noted is if PPCs were purely due to Trali or TACO, we would expect intra-op transfusions alone to show a strong association. The fact that peri-op exposure up to 7 days was more relevant suggests a more gradual multi-hit process beyond classic Trali-TACO definitions. For graft and survival outcomes, we noted that hemostatic blood products were associated with a 17% increased risk of graft loss. And yeah, no significant association found for 1 year patient survival. This figure shows the cumulative incidence of PPCs over time by transfusion status. The time on the x-axis is represented in hours and corresponds to 7 days post-LT. So patients who received transfusion had a higher incidence of PPCs compared to those who did not. For example, at 7 days, 31% of transfused patients develop PPCs compared to only 19% in non-transfused patients. So as we can see from the graph, the gap widens over time, which shows that transfusions may contribute to early PPCs with effects that persist in the post-op period. So why do transfusions increase PPC risk? That's the big question. There are 3 potential key mechanisms at play. So hemodynamic instability, transfusion leads to fluid shifts and volume overload, which can contribute to pulmonary edema and worsening respiratory function. There's also immune activation. Blood products contain mediators that exacerbate lung inflammation, making the lungs more vulnerable to complication. And there's also the pre-existing liver disease. So liver transplant recipients already have compromised vascular and immune function, meaning that transfusion combined with surgery creates a high-risk environment for lung complications. So these mechanisms suggest that PPCs are not just the direct consequences of, again, Trali or TACO, but rather the result of a complex dynamic between transfusion, surgical stress, and the patient's baseline condition. So they're already at risk due to their fragile status. So when we introduce peri-op transfusions, we add extra volume, inflammatory triggers, and immune modulation, all of which can tip the balance toward pulmonary complications. So what does this mean for clinical practice? How do we balance the benefits and risk of transfusions in liver transplant? So we can think of reevaluating transfusion strategies. We need to be more selective with transfusions, particularly in high-risk questions. But the question always remains, how can we minimize transfusions while ensuring patients still receive what they need? We can also optimize fluid management since volume overload contributes to PPCs. Better peri-op fluid control may help mitigate the risk. And also multi-center trials, larger studies are needed to refine blood management protocols, and also larger studies would help to further validate our findings in a bigger population. We can also enhance recovery pathways, incorporate goal-directed fluid therapy to reduce lung complications and improve post-transplant outcomes. So one of the big questions is, should we change transfusion practices based on the study? We're not talking about eliminating transfusion, but reassess transfusion thresholds, particularly in the post-op period. As mentioned, the data suggests we should aim to minimize transfusion, especially peri-op ones. So optimize fluid management to avoid volume overload, consider product-specific risk, especially with HVPs. So while more research is needed, our findings support a more restrictive transfusion approach in LT recipients. Ultimately, the goal is to personalize transfusion and fluid management strategies to improve survival and reduce PPC burden in LT recipients. So the final takeaway from all this is transfusions are potentially a double-edged sword where we need to balance necessity with risk. Thank you very much for your time, and I will take questions, if any.
Perfect. Thank you for that excellent presentation. I will now open the floor for questions. Just to start it off, based off of some of this data being back from like 2008 to 2021, did you find that there was any changes in terms of outcomes over the course of that 13-year period, or did care change for some of these patients?
I'll just go back in my confounder. So we also, and this was a key idea from Dr. Carrier, where we adjusted for the year of transplant to account for these potential changes that there may be in practice or protocol changes in transfusions practice, or even just practice in general. So yeah, I think that was a very good idea. But before I incorporated a year of transplant, I had estimates, and when I put the year of transplant in my models, my estimates didn't change that much at all. Yes, Dr. Choi, I think.
Yeah, that's great data.
Thank you.
Yeah, so I guess you had the 77% increase, right? In PPC, right? And then you need 17% graft loss, right? How much are you able to stratify the data when you think about I guess modifying transfusion or practice? So of the 77%, is there some and the 17% that have increased graft loss, is there something that defines that 17%, right? Is there right, are you able to stratify and the data more, right, so that to determine which of the 77%, I guess I'm totally not articulating here, right? Like if you think about modifying practice or transfusions, right, it's a subset, right, of those that get the transfusions that that undergo more PPC that actually undergo graft loss. So what about it is it that is something that separates the 17% from the 77% within the
77%? I think if I can answer this question correctly, the 77% increased PPC risk, it's with peri-op transfusion, but with any type of peri-op transfusion. That means this comes from like a binary indicator. Did the patient receive peri-op transfusions? Yes, no. And this is the increase that we saw. For graft loss, it's perioperative HVPs. So it's the HVPs that, increase the 1 year graft loss. I don't know if Dr. Carrier has a better explanation than mine, but I think, no, okay. So I think that's it. If I answered correctly your question.
Yeah. So I guess
that was okay. Okay.
HVPs are I guess kind of like the bigger problem, and the one you want to try to modify a little more. Yeah.
The research shows that HVPs are a problem in for PPCs. So we just found the same thing, but really like it carries over the immediate response. It really goes long-term, like it applies to long-term survival as well.
Okay, thanks.
Okay. Any other questions? I guess in that case, thank you for the questions and comments throughout today's presentation. And Ms. Amzallag, on behalf of CDTRP, thank you again for presenting. If anyone has any additional questions, comments, or suggested topics for speakers or things to cover, please reach out to Erica, and I'll put her email in the chat. And otherwise, thank you everyone for your time today and enjoy the rest of your day.
Thank you so much.